Okay. So we've gone through what an opioid overdose is, the effects on the central nervous system, some demographics and risk factors for overdoses, some patterns of use that feed into the risk factors for overdoses. We've talked about myths and facts about overdose, so now's the point at which we want to talk about how to respond to an opioid overdose effectively. We want to really emphasize throughout this piece that by watching this webinar, by taking Preventing Overdose Waterloo Wellington training, you're not receiving CPR training, but we are going to speak about it. We encourage people to get CPR training so that you will feel more equipped and be able to respond more appropriately should you have the unfortunate experience of having to respond to an overdose. But we really emphasize calling 911. The reality is that you're probably going to need help with whatever response you're going to do. And right now in many of our communities, we don't have access to naloxone as readily as we should, and paramedics do. Okay, so we're going to start with, we're calling an ambulance and we're putting the person into the recovery position. If the person's conscious, you're trying to keep them awake and talking as much as possible while you call 911. But going back to those myths, moving them around really could risk a fall. If the person's unconscious, you need to put them in the recovery position and call 911 for an ambulance. Putting somebody in the recovery position means that any fluids, vomit or blood or anything like that that might be in the mouth has the opportunity to come out instead of going down the throat, increasing the risk for choking. The idea is to get the person on their side as securely and as stably as you possibly can. It's not always going to be easy, and this is something we recognize in response to an overdose. If somebody has overdosed in a bathtub or on a couch or something like that, it's going to be very difficult to get them onto their side while also ensuring the stability of their neck and their back. This is a choice that unfortunately people get placed on as to whether it's more important to get them into the recovery position and onto their side, or whether it's more important to stabilize their neck and back. That decision might be based around whether the person's taken a fall or how far you have to move them. I don't have any recommendation for you, unfortunately, but the risk of choking is very high if they stay on their side. Okay. Once the person's in the recovery position, you're calling 911. This is the third time I've said you're calling 911. We do stress it. It's very important. There are barriers to calling 911, and we know that. We know that some people don't have a phone. We know that some people don't want their landlord to find out. They don't want police involvement at the scene. They don't want Family and Children's Services to find out about their overdose. So there's lots of barriers to calling 911. However, we just really say that calling 911 is important because priority of life always has to be the first concern. You're ensuring your safety and the safety of everybody else around you by checking the scene, using some sort of stimulation to check if they respond. Remember what we talked about earlier, that if somebody's experiencing an overdose, they're not going to be responding to an outside stimulation. You're checking for breathing, and you're going to begin CPR if the person's not breathing. Okay, so when you're calling 911, ideally you're not alone, and you can have somebody else call 911 and come back and let you know that they've done so. If there's nobody else there, of course you have to go and make the call yourself, which means leaving that person for a little while longer. In most communities, police will be dispatched at the same time. They'll come with the ambulance. And again, for many reasons, there's lots of barriers to calling 911. However, saving that life has to be the first priority. When you call the ambulance, they'll ask a series of questions. This is to brief paramedics on the situation before they arrive. It's ideal to stay on the phone if you can. I don't know about anybody else, but in a high-stress situation where maybe I'm alone, I might forget some of the CPR skills that I have. And having a 911 operator on the phone walking you through those steps might help a lot. Okay, so we're also ensuring our own safety and the safety of everybody else around us. You can't help somebody if you need help yourself. So in the event of any emergency, including an overdose, make sure safety comes first. That means checking the scene for anything that could be of danger to you, other people, or the person experiencing the overdose. It means responding to any other emergencies and ensuring the safety of the environment. This is an interesting one for me because someone that I know did respond to an overdose. The person was conscious. but she was well on her way into an overdose state. However, she was also parenting, and parenting very well, and never would have wanted to see her child have her child see her in a vulnerable spot. So the person who was actually responding to the overdose first had to ensure the safety of that child by bringing her to the neighbors. So it's really important to take this scan of what's going on around you and try to focus and try to be able to see the breadth of what might be going on around you in the situation of an overdose. We really emphasize that when any bodily fluid is present, such as blood, vomit, or saliva, to put a barrier between the fluid and yourself. We understand that if you're at a party and somebody goes down, the chances that you've got a CPR mask and some gloves in your back pocket are, they're pretty slim. So people have certainly gotten creative with condoms, with plastic wrap. Are they as good as a CPR mask and gloves? Probably not, but they are better than nothing. Okay? The idea is to always avoid contact with the fluids and to wash your hands really thoroughly immediately after giving first aid. Okay? So let's talk a little bit about CPR. Remember that opioids slow the central nervous system down. The person needs to be breathing to bring in oxygen, and the heart needs to be pumping to circulate the oxygen in the brain. For those of you who've had CPR training, this is going to seem pretty basic, but it's worth noting that at 1 minute without oxygen, brain cells begin to die, but survival is possible. At 3 minutes, we're looking at serious brain damage being likely. At 10 minutes, many brain cells have died and the patient's unlikely to recover. And at 15 minutes, recovery is virtually impossible. So in many communities, 6 to 8 minutes is an average response time once 911 is called. So the scenario is you're at a party, someone's gone down, maybe they just nodded off and fell asleep on the couch and nobody noticed for a little while. Somebody gets around to calling 911. You're still looking at 6 to 8 minutes average response time in many communities, by which time you're looking at many brain cells having died and the patient being unlikely to recover. The way to offset this is by moving oxygen through this person's body, okay, while you wait for emergency and first responders to get there. Okay, CPR involves two main components. One is chest compressions and one is rescue breathing. So chest compressions need to be at least 5 centimeters deep and at a rate of about 100 per minute. These are the guidelines, in an effort to create artificial circulation by manually pumping blood through the heart. What this comes down to, again, is you have to push hard and you have to push fast. Okay, so this can be something that's quite exhausting and quite difficult to do.
I've heard doing it to the beat of Staying Alive is okay. That's how fast you want to be doing the CPR, chest compressions.
So the rescuer might also provide breaths by either exhaling into the subject's mouth or nose or using some sort of a device that pushes air into the subject's lungs. That's only going to work if the airway is clear. So you have to open the airway by tilting the chin up and putting the head back, close the nose by pinching the nose shut, and ensuring that that airway is closed by looking for anything open, by looking for anything that might be blocking it. One key to remember when you're checking the airway is if you do see anything there, it's recommended that you don't reach past the back teeth to try to get anything out, or you're taking a chance on pushing something farther down the throat, which you then won't be able to get out. So the current recommendations place the emphasis on high-quality chest compressions over artificial respiration. A simplified CPR method involving chest compressions only is recommended for untrained rescuers. Chest compressions alone can at least circulate existing oxygen in the blood, and a full first aid response to an opioid overdose includes chest compressions and rescue breathing. Okay, and then if you're trained in the administration of naloxone or Narcan and you have it available to you, you would administer the recommended dosage by injection or intranasally, and you would continue CPR. If the person's still not breathing on their own after about 5 minutes, you would re-administer the dose and you would continue CPR. If the second administration doesn't stimulate breathing independently, it's not likely to be an opioid overdose. There's something else going on. There's something complicating it. And you would just continue CPR. So one of the signs of how effective naloxone is, basically if it doesn't work after the second administration, it's very likely not a pure opiate overdose or something else complicating it. You continue CPR and wait for paramedics to arrive. You do CPR until paramedics arrive, until the person starts breathing, until somebody else who knows how to do CPR comes and takes over for you, or frankly until you're too exhausted to keep going. The reality though is, in this case, if you're at that point where you're too exhausted to keep going with CPR, this person is at a high risk of death, and doing it wrong is better than not doing it at all. So if you're so exhausted that you can't push the full 5 centimeters, doing it wrong is better than doing nothing at all. Okay? If you did happen to use NALOXONE, then you would be disposing of your needles in the closest biohazard box, or margarine container, or peanut butter container, something that's solid plastic that can contain the needle until you can dispose of it properly. Okay? One thing that we really want to note is that NALOXONE does not replace medical intervention, but it does buy life-saving time. Okay? The question that this raises, though, is what is NALOXONE?
So naloxone is an opiate antagonist, which actually works by displacing opiates from their receptor sites. So the naloxone is basically just going into those opiate receptors, kicking the opiates out, and then taking over and grabbing on. That's the only job of naloxone. That's the only thing that it does. So if I give myself naloxone right now, and I don't have any opiates in my system, nothing would happen. One of the side effects from taking naloxone is if you're physically addicted to opiates, you are going to be placed into immediate withdrawal, and quite strong withdrawal. So naloxone can reverse the effects of overdose if used within a short period following an opiate overdose. It only takes about 2 to 4 minutes to work, and it only lasts for about 45 minutes. So after 45 minutes, the opiates, they can go back to their spot in the brain and put you right back into an opiate overdose. Another reaction that somebody could have to getting injected with naloxone is skin sensitivity to where they were injected. One way to think of naloxone is like an EpiPen. You know, it's the antidote to the opiate withdrawal, to the opiate overdose, just like an EpiPen is an antidote to a severe peanut allergy. It gets both people breathing again. A lot of people ask if by having naloxone, will people just use more riskier now because they know that they have this antidote to it? And my answer to that is no. You can compare that again to somebody with an extreme allergy, right? They're not going to go out and just eat peanuts because they can give themselves the EpiPen after. In my experience, when I had been Narcaned in the hospital, it was really, really confusing and really actually quite traumatic. I thought that everything was fine. I felt warm. I was going to sleep. I was quite comfortable. And then I started to wake up with this tingling and like this awful something just crawling all over my body. And then I started to become alert. I started to open my eyes, started to see things again. And then just this severe pain and cramping and and confusion, you know, so cold, so hot. It was all these withdrawal symptoms that I knew, but I had never actually felt so severely. Was only in this time, and they just happened so instantly and so severely, and it was really, really scary. After that, I think I started using a lot more responsibly because I never wanted to go through that again.